the first question I want to just ask about is it's really around timescale, and it occurred to me, Ben, while you were talking about getting involved before and during and after research. And what we haven't really emphasized is how long trials can take. And that therefore, if you get involved at the very beginning of a trial in a PPIE role, you may not be there at the very end, but it could be that you get involved at different stages. And I just wanted us to tease out a bit more about that aspect. Don't know if you want to comment on that, Ben.
Yeah, sure. I mean, I think one of the things is that it can sometimes take a lot longer than people originally or initially think it might. So and Nick may have words to say on this from his experience, that it can take several years to design and fund a study. And then the process of recruiting to a trial, particularly if it's a large one, if you want a few hundred people into it, that could take a long time as well. So that's another few years. We heard from Jackie, for example, that she was on treatment within the FLAIR study for 6 years. So, and then there's the expectation that there will be a result that comes out of it. So it's really not a matter of designing something in 6 months and then a year later you've got the trial results. I think we all have to be really patient with these, and it's kind of it's a generational thing, and some of these studies can last for a long time and take a while to produce those results, to read out, as we say. Nick, what do you think is good
I
experience?
agree. Yeah, I think it's a big sort of practice changing studies in with drug related studies are endeavors of a decade or more, really. So
Yeah.
there are many opportunities for patients to be involved from the start to the end. It's a good opportunity for somebody that has been involved from the start, because then as you go along and with the study, you gain, as a patient representative, you'll probably gain a lot of experience with this trial itself, with the condition, with etc. You also become slightly invested into the study, because you put a lot of effort and time into it, and it becomes your part. In my experience, they become part of the team, and it's very rewarding. There are also smaller studies which are very small, shorter observational and kind of all the other different studies that can happen within 6 months or a year, a couple of years. But generally speaking, in order to maximize the investment of a clinical study, they tend to be relatively long.
It's fascinating what you're saying, Nick, about becoming part of a team. So I know I was challenged not too long ago when I was part of one particular trial about not going native, if you like. And Jackie, I'm sure that you've always managed, you've got to sort of keep that distance, haven't you? As a patient representative, you're working with the team, but you still have to bring your own challenges and questions, haven't you?
Yeah, that's really important. You are definitely part of the team. You're working together to achieve a result in terms of the research question, but you've got to maintain that patient perspective. Don't get sucked into the researcher's psyche, as it were, in terms of the question must be answered at almost any cost. It's not like, certainly the trial management groups that I've sat on, sometimes the input that I've been asked for is, well, why do you think we're not recruiting very well? What are the elements of the protocol that you think are holding people back, or we're not keeping patients in the trial? And some of those are trials with, for rare diseases where recruitment can be very slow. And so every patient that is perhaps eligible is extremely precious and valuable to the research community, but also for that patient as well. Yes, so it's about sort of slightly being a little bit back and having that constructive overview on behalf of the whole of the patient body that you're representing. I think we're very fortunate, actually, as CLL patients. We have a relationship with our doctors that goes on for decades sometimes. And often that isn't isn't the same for other specialisms. So I do think as CLL patients, we're very privileged in often having extremely good relationships with our medical staff and medical colleagues.
Jackie, it goes both ways. I think it's a privilege for us to get to know our patients so well over such a long period of time. So, you know, I think we're sort of vested in the same, many of the same goals,
Yeah.
really. So, yeah, it's a real privilege. Anyway, there we are.
We've got a question here about talking about the difference between participation and then involvement and engagement. And I think what they're probably getting at is that the participation is if you happen to be on a clinical trial as a patient, whereas we're talking about patient involvement and engagement, which is one step removed.
Mm-hmm. I suppose, Hilary, there's no reason why, you know, members of a PPIE group would not be excluded from research simply because they're a member of a PPIE group. So if it is relevant to any individual, then it's relevant to them, and they have a free hand in it. The question then becomes, because of that, does that affect some of the objectivity, for example? And I think you just have to cross that bridge when you come to it, wouldn't you? What do you think?
I was going to say I can bring some perspective to that because I was asked to take part in a sort of not exactly a focus group, but this exactly what we're talking about today, about the initial sort of stages of a research project, quite a convoluted research project. And the company had engaged with NICE. NICE approached me because I'd worked with NICE on a number of other things, and so one of the things that I asked right at the beginning was, well, does my involvement at this stage preclude me from perhaps somebody who might benefit from this study? Does that preclude me from taking part in that study at a later date? And they were very careful and very kindly checked that clause in the relationship that we had, and in fact it didn't preclude me, and I was very happy to take part and offer a patient perspective on that potential study.
And we've got another question here about who decides which studies run in the NHS and at which hospitals, and are the PPIE roles in that process?
So the trial typically has a sponsor, or which is the one that will then dictate what centers and where does the trial go to. You can be different kind of scales. It can be local, because it can be a kind of local, regional, or UK-based study, or you can be talking about global studies that then involve several countries, etc. But typically, the sponsor will decide which centers are opened, and the criteria to those would be essentially people with, or centers with, track record of recruitment, because what you want to do is get people involved that will effectively get people into the study, because you want the investment you've got investment for this study that is usually time limited, and you want to stick to your timelines of recruitment, and you estimate how quickly you can do this. You spend a lot of time trying to figure out how long this is going to take, and how many centers do you need to do this quickly. And there's usually a balance between having as many centers as possible that will hope that if you were conducting a trial with 50 centers, or instead of 100 centers, you would have the recruitment, have the time, but with and how does impact the cost of the study itself as a global cost. So there's a balance to be struck there, and that's why typically the trials are usually skewed to the same centers that have already built infrastructure and a track record of the delivery of clinical studies. So it's kind of a self-fulfilling prophecy. The better you do, the more trials you're asked to do, and that works that way as a center, as a clinician, and we are aware that might sometimes make representativity a bit difficult, because then there's the geographical, sometimes there's skewed geographically the centers that are offering studies, and then but there's good examples of the country, and the Flare is a good example in which it was opened in many centers, and we were pretty confident that the representativity of the UK population was very, very well addressed. So yeah, I don't know if that answers, and if anyone wants to comment any further, but yeah.
So Troy, I think you were brilliant at challenging Ben. I think that's exactly the sort of approach that we want from a PPIE person, because whenever I've talked to groups of us, we always say that having confidence is just so important. So were there other questions that you didn't dare ask Ben, or were you happy to ask him all of them?
I think I asked nearly all of them. There was one further one which I was going to ask, which was when you're looking at, I'll call it research English, right? Because it's like translating from things like TP53 deletion to things which people like me would understand. How do people in a PPIE group look at it and go, right, I know what that means, and I'll translate it to English that non-clinical people will understand?
Yeah, okay, I think it's really interesting, isn't it? I think the whole area of language and who owns the language is fascinating. But in terms of ensuring that a study is transparent and understandable, that and when a potential participant is making a decision about being in a study, that they're able to understand what it means and why they're being asked to do it. I mean, jargon is really, where you have a lack of context or explanation of medical, technical, scientific terms, and sometimes you can't avoid those terms. They're there. They have a specific meaning and can be very important, but that's within a context and can be explained. So, for example, in a patient information sheet, then it may refer to prognostic groups, and it would the word prognostic is potentially jargon as well. So that the researchers should go some way towards saying, looking at particular subtypes or population groups within CLL we're talking about, that may do better or worse with certain types of treatment, and one of those markers of outcome could be TP53 or 17p deletion, and then explain a little bit more about that if it's essential. What you don't want is something that's going to confuse the issue, make it bamboozling or whatever. And as I say, if it's not clear to a PPIE group, it's not going to be clear to a potential participant either. So the onus is definitely on the researchers to try and explain something and put it into context, and then working with them to say, yeah, you're nearly there. I kind of understand it, but can you give me something a little bit more to make it clearer? So I think it's the onus is on the, when you're communicating something, is the onus is usually at one end of that to ensure that the technical language is explained. And there's part of the responsibility of the PPIE group is to tease it out of the researchers to say, what is the relevance and what does it mean, and to have that explained adequately for them, so that if broadly they feel that's a good explanation, then it's likely to work well. And sitting there in the ethics committee, we're sometimes faced with information sheets that are filled with jargon and have not had adequate PPIE, and then we have to send it back to them to say, please simplify this, change the language. And we have, to a certain extent, to do that role.
Ben, do you know if anybody's started using AI at all to try and get things written in different language?
Yeah, I'm not sure, but I suspect that will be the case, because you can use different registers, can't you, with AI, that you can tweak things to simplify language and reduce jargon, for example. So you can alter it for different sort of technical abilities or registers of tone. But you have to be careful with that, because the AI is simply a tool, and it still needs to be reviewed so that it makes sense and hasn't kind of gone overboard and lost the baby with the bathwater, as it were.
And we've got a question here, sort of moving on from AI, if you like, about imposter participants. So I don't know if any of you've had time to study the Times today, but there was an article in there about bots risk skewing clinical trial medical trial results, and wondering about, is this a problem with PPIE, and what can CLL support do to help avoid this? And I suppose what we can do is that we've got a register that we've created that's got people on it, and we feel we've got enough information about those people on it to know that they're people. You can't absolutely be 100% certain. We haven't met all of them in person, but we've certainly got enough characteristics, so we're aware of that as an issue. But times keep changing. Another of the questions is about the change that there's been with the UK Blood Cancer Research Network. So I don't know, Nick or Ben, one of you want to mention how the CLL Trials Group fits into that?
Nick, do you want to address that point? Just going back to the initial thing about data and bots and things like that. I'm not sure that this is a significant concern at the moment. As you say, Hilary, it's the process of having information collected directly from one person to another, where data is very, very strictly recorded and controlled and stored and secured. And there are, data cutoffs and people reviewing the integrity of that data constantly, that I'm not convinced at this stage that there's an opportunity for some kind of external influence to change that unduly. Maybe I'm being naive about this, but certainly at the moment, data is so scrupulously looked after and nurtured, with all the sort of the whole GDPR regulations and things as well, that it's not a concern of mine, and I wouldn't be concerned about a PPIE group being involved in something that could be data hijacked in some way like that.
No, thanks, Ben. So yeah, on the note of the sort of existing research groups, so just to put people into perspective, so I think the UK, the NCRI was a former structure where all the research groups for all the hematological malignancies were kind of held together, and that was kind of kept together by some funding that then has unfortunately been terminated. But there was a structure of patient involvement in that former NCRI structure, that, alluding to one of the questions, I'm very sure that the STAR group can learn tremendously from them. I'm not sure what is the status of that group, whether it has been dissolved or not, etc. But then that structure has been sort of translated or transplanted, if you will, into the UK Blood Cancer UK charity that's hosting these different research groups that have interest in different hematological malignancies. So the CLL study group is part of that, but it's also part of the CLL forum structure. And the CLL forum is being serving as an umbrella for this sort of group that essentially involves the same group of clinicians that are part of the CLL forum, and therefore it made sense to bring them together. And then there will be a group of patient representation in the UK, the Blood Cancer UK research groups, probably similar to the one that was available in the NCRI. But again, something that the STAR group I envision could work collaboratively very well with. Obviously, the idea and the role of the STAR group is make this very specific and very niche for CLL, as the remit of the CLL support is, and hopefully the other way around. I think, with some time and experience, when we hope that these patient representation groups can actually learn from the STAR group in the way it's being set up and worked, and the patient and the people and the representatives are being exposed to the clinical trials and trained, if you will, by these sort of resources such as this webinar.
I think I want to emphasize is that it's very early days with the STAR group and what we're doing, and we're learning all the time, and we haven't got all the answers, but we're very keen to get involved. We're very keen to encourage other people to get involved and to share knowledge, experience, whatever will help. And we've got more information on our website now. There's a really helpful comment that's just come into the Q&A, reminding us that we've been talking about clinical trials tonight, and there's far more ways that patients can get involved in contributing to research. So I think this is going to have to be probably a part 3 of a webinar in the future at some point when we talk about other ways of getting involved. But meanwhile, we're just going to run an exit poll, if you wouldn't mind just answering 4 questions as you leave. But thank you so much for being here this evening. Thank you so much to our speakers. I think it's been a fascinating opportunity to share information with each other and to answer some questions as well at the end of the session. So we very much look forward to seeing you, having looked at the theory tonight, on the 29th, when we're going to have our second webinar, which is going to look about the practice of PPIE. So that's on the 29th of October. You'll be getting information about that in the way that you got it about this evening. But if you could fill in the exit poll before you leave, and thank you all very much indeed for being here this evening.
Thank you, everyone. It's been a pleasure.
Thank you, Hilary. Thanks, Troy.
Thank you, everyone.
Thanks, everyone.